Hello, everyone. At the beginning, I would like to say sorry for being late all this time, and because of some technical problems within my laptop, I suffered a lot to get inside the session. So thank you for your patience, and thank you so much for being here with me today in this session. This is a free session for the difficult exam questions for part 3 MRCOG, and how can you prepare yourself regarding this kind of questions. In the last 3 or 4 patches of the exam, when it was online, exclusively online, some new kind of stations appear to the surface of the exam as in the teaching. For example, teaching previously was depending on skills and some instruments here or there or dummies, and how can you illustrate the practice. But through the online exams, some other kind of questions start to be in the exam, like discuss the audit, how can you critically appraise a paper, what about the maternal dashboard, and so on. So I tried to collect everything regarding to these strange topics, and today we will discuss them rapidly. At the first, I would like to say that the next exam in November will be a hybrid between the live and online exams. So prepare yourself for the live exam as well as you already prepared for online exam format. Okay, let's start. The first thing we would like to discuss today is the consent. In some stations, the examiner may ask you to take a full consent from the patient in front of you, because she will do cesarean section, emergency cesarean section, instrumental delivery, laparoscopic procedures, or laparotomy procedures, whatever the situation or the scenario is. We are following certain steps in consent to take a valid consent or obtain a valid consent. So the consent, for example, for a cesarean section, this is the format of the consent, mostly the most famous format in NHS. So you should be familiar with this format. In previous exam, the last patch of the exam before the online and the pandemic, there was a station which is asking for taking emergency cesarean section consent. They gave candidates paper like this, and the candidates start to fulfill the items. Okay, so you should be familiar with the consent form in exam, so that you can fulfill the spaces as much as hairy as possible. The first thing in the consent is it should be voluntarily, and the patient should be full mental capacity. These 2 points should be checked carefully. The first one is, you can say to the patient, the consent should be voluntarily by your acceptance, full acceptance, and after discussion with you all certain points, your sign is mandatory for this consent. For the second part, the mental capacity, this is not a clear point to be mentioned, but you can evaluate the mental capacity of the patient through the discussion. Sometimes, and it was a famous station, sometimes the patient was old age and she cannot recall the details of what you are discussing with her. So for example, you are telling her that we will do a laparoscopic bilateral oophorectomy, for example. Of course, this terminology is wrong. we are gonna do a keyhole surgery to remove your both ovaries, okay? We may find some problems and may have some complications like bleeding, like injury to the bowel, injury to the bladder, and so on. The patient will tell you like, so what is the name of the procedure? What we are gonna do? You would repeat. She will after that say, is my bowel, for example, at danger? Now the patient cannot recall the informations. So the mental capacity is not full. At this point, I have to stop the station, stop taking the consent, and preferably join you, ask your consultant to join you and inform psychological counselor as well to full judgment of the mental capacity of the patient. So be aware about these tricks. So number one in the consent is voluntarily, full mental capacity. Let's revise special cases. Sometimes 3-year-old patient with Alzheimer. Sometimes young patient coming with her mother and she's Down syndrome. Okay, so be careful with dealing with those patients. No jargons or abbreviations. If you are taking a consent from a patient for cesarean section, don't write LSCS. You have to write lower segment cesarean section. If you are gonna do a laparoscopic ovarian cystectomy, don't write it like this, or don't say the same expression. You have to say, we're gonna do a keyhole surgery to remove a cyst from your ovary, and so on. So no jargons, no abbreviations. Number 4, all complications must be discussed. Even those complications which are very rare, extremely rare, even death should be discussed with the patient. And this is what is known as Montgomery Rule or Montgomery Act. That to tell the patient every single possible known complication. I prefer in this point or at this section, because this is the most important thing in this station, is to classify complications into common, rare, or uncommon complications. The common complications, 1, 2, 3. The rare complications, they are serious, but fortunately they are uncommon, like 1, 2, 3, up to a very, very extremely rare risk, death. Number 5, always missed by many candidates, always missed. Possible additional procedures. What does that mean? If I'm gonna do a laparoscopy, I have to confirm that laparotomy may be needed at some point of the procedure, okay? So if the patient refused 100% the laparotomy, I cannot go for laparoscopy. If the patient refused 100% cesarean section, I cannot go for instrumental delivery because there is a risk of failed instrumental delivery. So the patient should be fully aware about possible additional procedures. In additional procedures or additional interventions also, you should remember very important 2 possible things. Number 1, high dependence unit admission at any moment. Number 2, possibility of blood transfusion. And at this point, you have to check, is the patient have any restrictions against blood transfusion, yes or no? Okay. This is a patient safety, very important thing. Number 7, you have to mention that the senior anesthesiologist will be involved in the discussion for anesthetic point of view, and he or she will discuss with you the possible complications related to anesthesia, and finally, clear signatures to the consent from your side and the patient side. These are the principles of consent, how to take a valid consent. For number 7, the clear signatures. If you are in online exam, you just have to mention that your signature will be taken. Just mention it. If you are in a live exam, you have to give the patient the paper to sign. Okay? It's like it's a play, and you are an actor, and you have to do your job perfectly. Okay? So this is number 1. Number 2, some important points regarding the mental capacity assessment. In some stations, not related to the consent, in other stations, like a young girl coming asking for contraception, or she's pregnant and want to terminate her pregnancy, okay? The mental capacity assessment is very important. And to understand how to evaluate the mental capacity, you have to remember that retain information and use this information as a part of the process making decision are very important 2 points to judge about the mental capacity of the patient. If the patient cannot remember what are you saying, if the patient cannot answer questions properly, for example, you are asking her a question, she's answering the question, a different question. You ask her about the last menstrual period, she's answering you by, I had the last sex 2 days ago. Now she's answering another thing. The mental capacity assessment says they will be treated as unable to make the specific decision in question. So I cannot take from them any consent. I cannot offer them any sort of treatment. So we need to find the lasting power of attorney, another person who can take the decision with the doctors for the best interest of the patient. Sometimes if this person is not exist, so the doctors should seek the advice and permission from the court directly, especially if we're gonna do a permanent procedure. For example, if a Down syndrome patient, she's 25 years old and suffering from multiple huge fibroids, okay, her mother coming with her, she's asking for hysterectomy because there's no plans for fertility. I cannot take only her mother decision and apply it because I'm gonna do a permanent procedure, hysterectomy. So at this point, I need to seek the advice and permission from the court. So this is how can you evaluate the patient from the mental capacity. Now, another very important pillar of the NHS principles, the confidentiality of the patient. The confidentiality of the patient always secured in NHS system. Even, you know, between the medical team staff. I am the doctor in charge responsible for case X. Mrs. X, in my file, in my access to the system. You are my dear colleague in the hospital, in the medical team. Unfortunately, you have no access to Mrs. X files because of the confidentiality. Unless in a very limited situations, you have to break the confidentiality, okay? Breaking confidentiality should be done in, for example, communicable diseases. A patient with recently discovered HIV, and she refused to disclose this information with her partner and her family. For example, I need to advise her once, twice, and after that, I can break the confidentiality. A patient which is, for example, in crimes, the patient suspected to be involved in a crime. So I have to break any confidential information related to her, and so on. So a patient with blood-borne disease does not want to disclose and refer her to the hospital because they know people who work there. You don't have to disclose at the first meeting. You have to offer her once, twice advice, and after that, you can disclose the information regarding the blood-borne disease. Okay? Relationships and STIs, all of these things are very importantly to be hidden sometimes up to limit. If the patient will, if the patient decision will affect the community at this moment, simply, I have to break the confidentiality. I prefer in the exam that in these kind of stations, you have to involve the Caldecott guardian with you. You have to ask for the Caldecott guardian to join the discussion in this kind of stations when you're gonna break the confidentiality. On the other hand, some stations which are very common in the exam, you cannot break the confidentiality ever. Despite the huge stress will be work on you. For example, famous two stations. The first station, a mother of Miss Y, she is coming to ask you what was her daughter doing in your clinic in the last week. Her daughter actually was pregnant and she came asking for termination of pregnancy, and I did the termination. Her mother now is asking, what was she doing here in the hospital? I need to check her. You simply cannot break the confidentiality. You have to spend the 10 minutes in negotiations with her mother to convince her about her daughter's confidentiality rules. You will be under burden, stress, discussion, negotiations. Sometimes the mother may be loud voice, may be angry, may be aggressive. You have to cope with these stresses, never to disclose. The second scenario, which is very famous as well, a daughter is coming asking for the biopsy results of her mother. The endometrial sampling was successfully obtained from her mother last week because of postmenopausal bleeding, and she is now here to take the results. Where is your mother? She's very tired, she cannot come. She sent me to take the results. I'm very sorry. The results are confidential. I am her daughter. I am sorry. I will sue you. I will sue the hospital. You should never change your mind. You have to convince her. Now, I will give you some important tricks to bypass these kind of stations smoothly. You know, it's exactly like dealing with your child. If your child is, and this is a famous example, by the way, if your child is 24 hours holding the mobile, playing games, watching YouTube videos, if you take the mobile suddenly from his hands or her hands, he will be very anxious. He will start to cry, you start to shout, okay? And as same as adults, they will be very anxious if you just refusing their requests because of the rules. Okay, this is a very annoying act. So what can I do to solve this problem? With my child, I will take the mobile and put a chocolate in his hands. He will be very happy and he will forget about the mobile. For the adults, I have to prepare my mind, myself, to offer different kind of help rather than breaking the confidentiality. For example, in the patient asking for her mother report, histopathology report. So what do you think if we can, for example, send the report directly to your mother on her email or as a post, for example? Is it acceptable? Yes, it is, but I need to check the results. I'm so much anxious about the results. Is it a cancer or what? So we are too much afraid from the result. I need to know it now. I'm sorry, you know very well that the confidentiality rules makes me so much restricted to disclose any information right now. But I can send the results within few minutes to your mother's email if she had one. Okay, so what do you think about this? You have to give the patient or the role player different kinds of solutions. Don't just be so much tough to say, no, these are the rules. She will be anxious. She will attack you aggressively. She will be angry. Okay? This is very important when you are dealing with confidentiality. I have many candidates under pressure, they change their minds. They say, okay, I will take the consent from you that you are the responsible person for the patient and take the results as you wish. Big fail in the station, big fail, okay? So once you take the decision properly that you should never disclose the confidentiality, keep the confidentiality, involve the Caldecott guardian, and try to find any other help. Okay, for example, a mother is asking what her daughter was doing in the clinic. You cannot break the confidentiality, but I can say your daughter is fully responsible about her decisions. Her mental capacity is great. I encouraged her strongly to disclose everything with you and with her parents, her father, you as well. So you can ask her directly. She will be cooperative. You can solve a problem like this. Yes, you can. Pagalo, you raised your hand. Please open the mic and ask your question.
Sir, good afternoon, sir.
Good
I'm
afternoon.
Pagalu. Sir, in this question, what you have described now, the daughter comes that the mother is sick and she cannot come and collect the report. Can we ask that whether the mother has given any advance directive or she's having the lasting power of attorney?
Yes, if the mother, you can ask, for example, if the daughter has agreement as the lasting power of attorney, yes or no. But of course, in this kind of stations, the daughter has no agreement or document supporting that she is the lasting power of attorney, because if she had, the station will be finished. Okay, if the daughter has the lasting power of attorney by advance directive of her mother, yes, of course, you can disclose. But in this kind of stations, the clue that they has no lasting power of attorney document, and just they would like to know the results without any medical legal aspects of the NHS, against the NHS rules. So of course you can ask this question as a part of negotiation, but
Yes, sir.
it will never be in the station, because you have to continue the discussion later on. Thank you so much. You can ask this question. This is a very smart question, of course. If result is not a biopsy, if it is scan report done due to the PMBA, they can discuss ultrasound with daughter. Ultrasound results, biopsy results, any documentation, any information related to the patient, you cannot disclose. Even full blood count analysis, urine analysis, you cannot disclose. Perfect. Another important point I need you to understand, you all to understand, the social services work. Who to refer to the social services and child safeguarding team? The people or adults without capacity, without mental capacity. I have to offer social services involvement in the management plan. This is basic step in the management. I cannot manage adults without capacity alone. Okay, adults with capacity, sometimes I need to involve the social services and safeguarding teams, especially if we are facing a social, medical, legal, complex problem like domestic violence, child sexual abuse, crimes, rape. Okay, so I need eagerly to involve sometimes police and 100% the social services and safeguarding team. Homeless patients, immigrants, I need to involve the social services. These are basics. Okay, the safeguarding leads in the hospital, we have many leads in each hospital for adults, for frail or vulnerable adults, and for children and refugee as well. We have specific social services for refugee and for homeless patients. So once you find any scenario related to the high risk group of people for social, medical, psychological, or mental complex problems, don't be hesitated to involve directly safeguarding and social services teams. One of the famous stations in the exam is the handover stations. You are working in a busy hospital and you will start your shift and you are taking the charge working from your colleague, the handover regarding either a certain case or a labor ward overall. Okay, you should remember that we are following the S-bar technique when we are going to do the handover. Situation, I need to tell my colleague or sometimes the role player, sometimes the examiner in structured discussions about the situation. You know, I had this station in my first exam, MRCOG part 3, when I failed in the first trial, because I did not understand the station. I read the scenario. You're gonna see Dr. Roberts, I think, Roberts or Robinson, something like this. And you will discuss with him a case in the labor ward to finalize the plan of management and so on. This scenario is directly related to the handover S-bar technique. I get inside the cubicle and I found a female examiner just inside the cubicle. So I misdiagnosed. Where is Roberts? I don't know. I don't know. Okay. So I thought this one is the patient. So I tried to take history and I tried to start to take more details about the situation until she stopped me and she said, I am Roberts. I am Dr. Roberts. I can't understand. She said, my name is, okay, for example, Catherine Roberts. Okay. So Roberts is the family name. So I then started to realize what's going on and I started discussion with her directly. Sometimes mental block may happen in the exam, but don't forget that we have some scenarios and some cases in the exam related to the handover technique. Situation, the patient details, patient location, where is the patient? Is the patient in the ward or high dependence unit? Okay. What is the main problem right now? Background, the history, the detailed history of the patient, the main complaints, the reason of admission, the past medical, surgical history, allergies, and so on. What about the right now assessment, the vital signs examination details? And finally, the situation is, for example, a prima gravida, 32 weeks of gestation age by ultrasound and last menstrual period. She came to the A&E with gush of fluid and the rupture membranes is confirmed by speculum examination, and her examination right now is completely free. So the recommendations finally is erythromycin, for example, antibiotic cover for 10 days, repeat ultrasound scan for fetal well-being, and vaginal swabs may be taken. Okay, simply this is the handover. So you should follow the handover steps in structured discussions like this. In 2017, a station for maternal dashboard was first time introduced in the exam, part 3 examination. And it was sometimes a shock to overseas candidates because they don't know anything about the maternal dashboard. A maternal dashboard is a method to evaluate the practices in the obstetric unit and the relation to the outcomes monthly. Okay. The policy of the department, for example, responsible for the statistical cutoff value of each procedure. I will start by this one, for example, the maternal newborn dashboard for a certain hospital. The rate, number 2, the rate of episiotomy in women having spontaneous vaginal birth. You can see here 3 kinds of colors, and it will be like this exactly in the exam. Okay. The green color means we are in the safe zone practice. The number of episiotomies is just matching well with the standards of the department. The yellow zone means the number of episiotomies is higher than the standard, but we are still within accepted parameters, but we need to revise the practice sometime. The red zone is the alert zone. The number of episiotomies are really far away from the standard. So we need to revise the practice urgently to know why our medical team is doing episiotomies many times in the last month. Okay, so it's very easy. Now, I don't know, where is the pen? I can see the pen here. You can see here, let's follow. Rate of episiotomy in women having spontaneous vaginal birth. The rate is 14.1%. Where is this number according to the colors panel? Aha, less than 13%, we are in the green zone. Yes, 14% to 17%, it's the warning yellow zone. Aha, I need to do urgent, I need to do some meetings to revise the practice, asking senior obstetricians to follow juniors and to know why episiotomies start to increase in our department. So the status is yellow and the rate is 14. Excellent. Let's take another one. The number 1, 2, 3, 4, 5. Proportion of women delivering at term who had group beta streptococcus screening at 35 to 37 weeks of gestation. Now we are in the green zone. Yes, we are in the green zone. So there is nothing to be done regarding this practice. Okay. Most probably in the exam, you will have 2 or 3 papers like this. Your eyes should be always regarding the status. The status, okay? What to do if in red zone? Aha, let's take the steps. For example, number 1, proportion of newborn screening samples that are unsatisfactory for testing, red zone. Number 1, urgent appointment with the whole medical team. Involve neonatologists with you in the discussion. Number 3, audits should be conducted to improve the practice. Number 4, the risk management team also should be involved. Okay. Number 5, after the audit, we have to implement the recommendations to keep this problem within the agreed standard, the green zone. According to the problem, you have to think about the solutions. Sometimes the rates of cesarean section, for example, rates are very high in the department and the status is the red zone. What should we do? The same, asking seniors to join juniors, supervision, proper evaluation of the cases by senior doctors, induction of labor at 41 weeks, partogram should be followed in the management, augmentation of labor and CTG should be there as well. One-to-one support should be checked, audit should be conducted, and so on. Okay, these kind of discussions are very open discussions, so you can say whatever you want, fulfilling the most important terminologies like audit, like risk management team involvement, senior opinions, consultant supervision, the heavyweight terminologies. You have to use these terminologies in the discussion. Otherwise, it's open discussion. And the aim of this discussion mainly is to assess if you understand what is meant by maternal dashboard, yes or no. The risk management, RCA, is the process of examining what happened in order to establish how and why an adverse event occurred. We are not aiming to blame anyone. We are not aiming to incriminate anyone. We are aiming to know why the problem happened and how can we prevent this scenario to happen again. Okay, we are in risk management teams working. We are aiming to improve the quality of services so that we can improve the outcomes. One of the most important pillars of the risk management is conducting audits. And all of you knows the principles of audit cycle and how can we implement the recommendations of the audit. Should be undertaken by more than one person. The risk management involves teams, not only one personnel. And we have many pillars in the risk management, starting from raising the awareness, not only for the patients, but also for the medical team staff regarding the patient safety, understanding the patient safety and how to engage clinicians with you, training and education, teamwork principles, forms for risk management, and communication strategies, mainly by the SBAR. Design for safety, the handover, the care bundles, the standardizations following the guidelines and protocols. How to collect and analyze the data, root cause analysis, benchmarkings, audits, involve others in the discussion from other subspecialties, and finally, how to conduct successfully incident reports to have a feedback about the practice and how can we develop the practice from different kinds of views. Sir, it reports missed in informing patient what to do. You are asking about a certain scenario. Okay, I will tell you about this scenario. A patient came to the hospital with a mass in the cervix. Biopsy revealed cancer cervix. The patient was a part of national screening program, but in the last 2 visits, she missed the last 2 visits of the screening program. When the risk management team involved, the woman changed her address and the team of screening program was not able to find her. Now, something like this, some information was missed regarding the management plans of the patient. How can we manage? Follow the strategies. Follow the strategies. Simply, number 1, duty of candor. If the patient in front of you, you have to confess about the mistake. You have to be honest, transparent, apologize to the patient, but never to incriminate anyone from the medical team. This is the duty of candor. Number 2, urgent involvement of the risk management team to start the root cause analysis and fulfilling incident report and start the pillars of risk management, which exactly in front of you in this slide. Activate the awareness work, collect and analyze the data, audit conduction, root cause analysis, incident reporting, involve seniors, involve multi-subspecialties related to the case, care bundles activation, standardization revised regarding the guidelines and the protocols, and so on. So in such scenario, my dear, you have just only to add the duty of candor work because of the mistake happened from our side, okay? So all these algorithms of risk management to be told in red alert maternity dashboard, and it should be told in any case, complicated case, you know, any complicated case. A patient, she came to the hospital, for example, with abdominal pain. The patient received some painkillers and discharged from the hospital. She came back, collapsed, resuscitation successfully, and then there was a ruptured ovarian mass, for example. The ovarian mass was missed in the diagnosis. Where is the mistake? It's in our side. the medical team mistake. So I have to do the duty of candor and then follow the risk management, all pillars. You can apply this with any complicated case in any scenario. Okay? You got my point, Fatma? Is it clear, everyone? I hope it is. Yes,
Yes,
perfect.
sir.
Yes, perfect. Okay. Excellent. Now, there is some problems like never events. Okay. This is what I'm talking about just few seconds ago. If you have a case with never event, like famously missed the swab post-operative or retained instrument post-operative, okay, this should never be happen. What should I do? The woman came back after 1 or 2 weeks with offensive vaginal discharge and high temperature, vomiting, tenderness over all the tummy, and accidentally you discover that there is a missed swab deeply in vagina. This is a never event situation. Apology, duty of candor, risk management team involvement, and start to apply the all pillars of risk management. You got my point. Wrong site administration of treatment, wrong site surgery. And don't say it never happened. It happened with me. The wrong site surgery. It happened with me. So here in Egypt, it happened with me here in Egypt, fortunately not in UK, okay? Because if it's happened there, it will be a very, very big problem. One of the most important things, you know, sometimes the scenario may be more difficult. Now look at this. You did a procedure for a patient, and the patient came back to the E&D, one of your colleagues meet the patient and discover that there is a missed swab. What should you do regarding the appointment with the patient? This is the station. All people will forget a very important practice point regarding the UK principles. You will apologize to the patient. You will, you know, duty of candor rest. Exactly. You will do the same. But if you are the person who carried out the procedure yourself, you have to say, and I will put this event in my portfolio myself. And this is exactly what is going to happen in UK if you did this problem. Once you say this, you will gain the full mark in the station. I will put it in my appraisal, in my portfolio. This is critically important to be remembered. This is a part of honesty. In UK, they are not looking for brilliant doctors in surgical skills or in knowledge, because skills, knowledge, they are things will be learned by time and by supervision, but they are looking for morals, for ethics, for people that they can carry the responsibility. So you have to mention this in never event problem if you are the person who is involved in this problem. A rapid review about the structured discussions, because I felt the last 2-3 years of work and in examinations, I felt that people are doing very well in simulated patient tasks, but they suffered a lot in structured discussions. I don't know why. Now, in structured discussions, I need you to remember 3 points. You have to cover 3 points only. Number 1, show the examiner the systematic approach thinking. Don't answer any question haphazardly. What are, you have a case of postpartum hemorrhage. What are the initial management steps? I will go to the patient. I will do ABC resuscitation. No. If the patient is not collapsed, I will do bimanual examination to assess the amount of bleeding and the tone of the uterus. Yes, okay. Before that, I will insert wide port cannulas bilaterally, and I will start fluid resuscitation urgently. Yeah. Just before fluid resuscitation, I will take bloods for cross-matched blood and blood investigations. You actually remember everything. You mentioned all points, but in a haphazard, non-systematic way, you will lose marks, 100%. It is not related to how much information you are saying. It's related to how you present your knowledge. Systematic approach thinking. You have in each question, most probably, you have to do or show some classifications. What are the complications of diabetes in pregnancy? Miscarriage, congenital anomalies, macrosomic baby, hypertension, DVT, postpartum hemorrhage, blah, 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 blah. Okay. You mentioned more than enough points, but in haphazard way. You have to start your answer like, we have fetal complications and maternal complications. Fetal complications includes miscarriage and yes, exactly, maternal and fetal complications. Intrapartum, antepartum, postpartum complications. This is another classification. It doesn't matter, okay, which classification you choose, but the examiner is concerned about this candidate is able to classify the answer, okay? I can use this complication, and I can use this classification, I can use other classifications. It doesn't matter. This is number 1. Number 2, justification. I will accept most probably any answer if you justify why. Many candidates are doing this mistake. What are the investigations required for this scenario? Yes, full blood count, liver function tests, kidney function tests, electrolytes, serum electrolytes, and urine analysis. Thank you so much. You will have the half mark, never the full mark. Why? Because you cannot mention why you are asking about this investigation. If I asked any person in the street, if we have unwell patient, what investigations you may ask for, he will say the same. We will do blood picture, we will check kidneys, we will check liver. Okay, now you are exactly like a non-medical person. You have to tell me full blood count to check hemoglobin levels for anemia, TLC for infections, platelet counts for bleeding tendency. We have to check the liver functions because of 1, 2, 3. Kidney functions because the patient is blah, blah, blah. Okay? You have to justify your answer. This is the second most important point. Number 3, and the last point I'm waiting for in structured discussions. Communication with a colleague. This domain is divided in 2 main things. Communication with the examiner in front of you and communication with other subspecialties involved in the scenario. So in postpartum hemorrhage, you will say, call for help. I will call for help. Okay, you didn't mention which people will be involved to help you. You have to say, my senior obstetrician, hematologist for cross-matched blood, trained nurse in evaluation, anesthesiologist for resuscitation. You have to mention people, okay, people with you. Pretty, I'm just giving you an example, okay? If you request, for example, liver function tests, in this case, you have to mention why, okay? If you, for example, patient with hyperemesis gravidarum, okay? What are the investigations you will request? I will request full blood count because of 1, 2, 3. Electrolytes, because hyponatremia is a very important sign for disturbed conscious levels in those patients. I need to check sodium, potassium. I will ask for TSH because TSH is increased simultaneously with hyperemesis patients, and so on. Just an example, my dear, okay? So involve people with you in structured discussions, please. 100% of structured discussions, we are looking for somebody to join. If you cannot find anyone, involve psychological counselor. Okay? We are respect psychological counselors so much in UK. A decision does not need to be taken at the end of the station. However, different treatment options should be discussed. Follow the examiner's agenda, not your agenda. Follow the role player agenda, not your agenda. If I say, for example, I will explain this for you, because many candidates are asking me this question. Sometimes the role player may interrupt me and asking me a question. What should I do? 90% of candidates are saying, yes, of course, I will answer your query just after finishing my questions. Fail. I will give you fail in communication. And if there is a lay examiner in this station, he will give you fail. Put yourself in the place of the role player or the patient. Now, for example, Pretty, you are asking me a question just right now. Am I right? If I said, yes, if I said, okay, this question I will answer you later after finishing my talk. What will be your feelings? You will be so much embarrassed. Am I right? So this action is completely wrong. Why people did the same action? Because they are following their agenda. I have the history in my mind. I need to ask my questions rapidly to fulfill the history. This is a major mistake. If the role player stopped you and asked you a question, follow her concern. Follow her concern, because she is instructed to direct you in the station. As same as the examiner in the structured discussion. If the examiner stopped you and asked you a question, answer the question directly. Don't follow your agenda. This is a major mistake. If you have a scenario for a patient with, for example, a patient, she's 25, married 2 years ago, and she is suffering from increasing weight and hirsutism. The ultrasound shows pearl appearance, necklace appearance in the kidneys, which is matching with PCO. My brain automatically will translate these informations into the patient is seeking fertility. I will go inside the cubicle and I will start talking about the lifestyle modification, weight loss, exercise, and taking vitamin support, and then I will offer her induction of ovulation and blah, blah, blah. Okay. The patient will stop you and ask you about the hirsutism problem because she's really annoying her and she cannot go to swim or maybe with her friends or something. Yes, yes, of course, we will solve this problem. But tell me about how many years or how many times you are trying to conceive or having a baby. I'm not looking for a baby. I have no partner, okay? I need to solve the hirsutism problem. Sometimes the discussion may be far away. I know I'm PCOS patient. I read about the risks. Of possibly cancer of the womb because of my problem. Now the whole station will be regarding the reassurance, offer follow-up, offer withdrawal bleeding treatment. This is the whole station of PCOS. It is not related to fertility. If you still following your agenda, you will lose many marks. Follow the patient's agenda. So, sir, can we ask, may I know your preferred concern? Exactly. You have to start the discussion right now by asking her, can you tell me what is most bothering you? Can you tell me what you expect from our appointment today? Exactly. These questions are very smart. Rather than following the schemes, you know, in the last exam, I swear, in the last exam in May, I was in a very famous station. However, I examined in this day 28 candidates. After the finish of the exam, we have examiner's briefing session. Let me say that all examiners were really unhappy because they said exactly all candidates are copy-paste candidates. They are using the same sentences, the same starting questions, the same history taking in order of questions. This is really abnormal. We are not machines. You have to build up your own character in the exam to be different. If you are different, you will pass with a good grades. If you are different, all people doing the same. Hi, my name is Dr. Hassan, and I'm one of the senior doctors in the clinic today. May I confirm your name and age, please? Okay, thank you. So before starting our discussion, I would like to ask you a few questions, if you don't mind. And then taking the full history, not relevant history. Okay, not relevant history. Spending maybe 5-6 minutes taking history. What are you doing? You will lose other domains. Okay, so relevant history, smart, open questions. Don't ask like closed questions all the time. You are asking do you have any medical disorders? No. So any regular medications you are taking or you are taking or prescribed by your doctor? The patient has no medical disorder. Why you are asking about regular medications? This is very strange. Okay, if for example, I had this case a lot of time. 70 years old patient, 70 years old patient, okay, with ovarian mass, suspected cancer. When taking history, the candidate is asking, do you smoke? Any alcohol drinking? Any recreational drugs? this question is enough for me to give him borderline, fail to borderline in information gathering. This is a relevant question. You are asking a grandma, 70 years with cancer, about recreational drugs, which is unlogic. If you are in infertility station, and then sometimes you are asking about, are you taking any contraceptions? She is asking for fertility. She is seeking a baby, and you are asking about contraception. What are you doing? Okay, so what I would like to say is, you should start from now to build up your own character, your own smart questions, open questions. Now, when I would like to ask about smoking, alcohol, recreational drugs, I would say, for example, so do you have any social habits that you think it may affect your life, your health? The patient will understand what I mean. That's it. I'm not wasting time. I'm not wasting effort. I'm asking the smart questions. Okay. Of course, in structured discussions, you have to speak freely with medical jargons because you are dealing with a colleague. The candidate fails to read the question properly, or improper time management. Please notice that in the online exam, the timer in front of you, so you can barely manage your time. But in the live exam, there is no timer in front of you, so you have to be smart enough to estimate roughly the 10 minutes. Some people in structured discussions are markedly affected by the examiner's reaction. The examiner's was so silly. The examiner's facial expressions was very rude and very tough. The examiner was smiling for me. Wow. Maybe the smiley person give you fail, and the tough person give you pass, because examiners' facial expressions and reactions are not related to your performance. So don't think like this, please. And finally, you should be smart, ready, confident, and formal sometimes. And later on, in further sessions, I will tell you how to be formal and when should you be formal, and when you should be friendly, when you should be conservative in the discussion. In each situation, you have to show another aspect of your personality. Finally, I would like to give you a very small hint about the critical appraisal of a paper. Okay. How to critically appraise a paper. This is one of the, it was a fixed station in the old fashioned or format of MRCOG part 2B. When this session will be finished in 5 minutes exactly. I'm sorry if I was so much talkative, but I'm always would like to give the people all possible points and all beneficial points. Yes, okay, yeah, that's it. I got it. Okay, so the critical appraisal of a paper, it depends on certain points you will fulfill in the discussion. Comment on, number one, the author and the colleagues who conducted this study. You have to mention the names, okay, as a part of respect, as an important part of evaluation, because names, the author's names, the affiliation are important to judge the credibility and the beneficial aspects of the paper. For example, The Royal College papers are completely different from another medical school body which release papers. The year of publication should be mentioned as well in the evaluation. Very old publications should be eliminated, or at least should be mentioned to evaluate that the paper is old. The topic itself, is the topic is interesting or really had impact on the practice, the patient's safety, the patient's improvement outcomes, the doctor's knowledge? Is it an interesting, important topic, or it's just a sophisticated rubbish topic? What about the conclusion of the paper and its implications? You have to comment and go to the conclusion chapter to discuss this. Now, I used to follow the B code when I was discussing the details of the paper. What is the B code? B, population and problem, the sample size. This paper was conducted on 50 patients. Another paper is conducted on 500 patients. Which one is more valuable? The 500. So the sample size and the problem, P, should be mentioned in the evaluation. What kind of interventions used? Is it just a test, or we start to use a certain treatment or a certain procedure? Comparison, including the type of study and statistical analysis. I would like to mention that this type of study, look at this, just a second. The type of study, it was either case control, cross-sectional, prospective cohort study, or RCTs, randomized control trial. Is that make a difference in the critical appraisal? Yes, of course. From down upwards, RCTs and systematic reviews are the strongest evidence in evaluation. They are the best. Core prospective study, a study built in future, it's more accurate than a study depending on old data, like in case control, retrospective study. So case control and cross-sectional, they are not very much strong studies. Core prospective study is strong. RCTs are perfect with systematic review. So this is how can you comment on comparison, C. What about O? Outcomes, results. Discuss, just read the results and discuss the results. It's easy. And finally, what about the design of the study? How the design of the study being evaluated? Now listen to this. You have to comment in the design about the font of typing, the colors of the paper. Is there in this paper any diagrams, tables, pictures that make reading this paper more interesting? Okay, look at this. If I make a paper and all the paper is black and white in color, it will be interesting for anybody to read it? No. But if I use simple colors like pink, like blue colors, sometimes green, like in TOG articles, okay, give more value to this paper. The font, is it easy to be read, or I need to magnify and make zoom in to read? Okay. And if, of course, the paper is supported by tables, illustrations, diagrams, flow charts, it will be more valuable paper. This is what is meant by the design of the study. Inclusion and exclusion criteria, is it randomized or not? Is it multi-centric study or not? are the comparable groups suitable for the study, and then comment maybe on statistics. This is simply the critical appraisal of the paper. This seems to be very difficult to many candidates, but actually it's a guaranteed station to pass. If you follow these questions and mention commenting on each single point separately, you will have full mark in this station. This station, sir, where audit should be by the same method as audit. Mary, I cannot understand. The audit, you mean if I have a station like this, audit, not a critical appraisal, it will be the same. The same. Now look at this. There is a part in the audit which is in the cycle, maybe the third step, collecting and analyzing the data. Exactly, you will do the same points. Okay. The collecting data may be retrospective or prospective. I suggest prospective is better because it gives more reliable information. Retrospective is easier and takes no time, but many information will be missed. Okay, so you will, in audit, you will involve some important points from the critical appraisal of the paper inside the audit cycle under the term of collecting data and analyzing data. Okay, so of course you can interpret both together to fulfill all points. I think I finished. So I hope this introductory session and pre-session for some difficult scenarios being useful for most of you, and I will be very happy if you have any questions to answer your queries right now. This is the time of questions. So any questions? Great. So it means that I am a good teacher, by the way.
Sir, sorry to bother you. I have a question.
Yes, sure.
Yes, Assalamu alaikum, sir. Sir, if the question is like there is a critical appraisal of shoulder dystocia, in that case, how to like we make the critical appraisal in the same way?
The critical appraisal is related to evaluation of a study, maybe a study, maybe a PIL, maybe a TOG article, a scientific impact paper. So it is not related to evaluation of clinical situation or even a guideline. Look at this. Guidelines are re-evaluated by audits, not by critical appraisal. So shoulder dystocia, how it may come like a critical appraisal situation. There is a paper, a new paper, or PIL, for example, giving a patient information leaflet regarding shoulder dystocia for the patient. Please critically appraise this PIL. Okay, so you will follow the steps, design the language, is it clear or not, any pictures, any contact numbers, what about the knowledge, the topics, the body, the author, the colleagues. You will fulfill the steps. Okay, otherwise there is no critical appraisal for practice, because the practice will be evaluated by audit, as well as the guidelines will be evaluated by audit. Okay.
Thank you very much, sir.
Thank you. Thank you. I wish all the best to all of you. Yes.
So, was the labor ward prioritization was discussed?
No, we didn't do labor word prioritization. We did another points rather than the labor word prioritization. But if you would like to have a session with labor word preparation for free, yes, I will be very happy to do 2 stations with labor word preparation, because we have some tricks regarding how to manage labor word preparation. I know this kind of stations in exam is very long, very long station, and maybe more than 90% of candidates are not able to cover the whole station in 10 minutes, okay? But we can manage everything in less than 10 minutes, 8 minutes maybe, by another technique. How can you use our technique to fulfill all points in labor word preparation? So I will check with mid-exam, and I will be happy to announce about a session for 30 minutes to show you how can you deal with labor word preparation. It's my pleasure. Yes, of course. Thank you so much. Thank you so much, my dear friends. I wish all the best of luck to all of you. And I was really happy that you joined this session for today. Thank you. I'm really thankful, and see you soon. If you have any queries or any problems in studying preparation, don't hesitate to contact me directly or to mention me in the mid-exam group. I will be available. Have a nice day and nice weekend. Bye-bye.